Hi, welcome to Chapter 8 on Somatic, Symptom, and Dissociative Disorders. When we talk about somatic symptom disorder, these are disorders that involve physical symptoms and complaints which suggest a presence of a medical condition. However, there's no evidence of physical pathology, and oftentimes we can't find a medical reason for the symptoms or the complaints. I would say these are some of the most complex to diagnose and to deal with because oftentimes the physical complaints and symptoms don't match up with findings when they visit a doctor or a specialist. What are some examples of somatic symptom disorders? We've got hypochondriasis, somatization disorder, pain disorder, and conversion disorder. I would encourage you to look in your book on Chapter 8 and just make sure that you understand a definition of each of these. First is hypochondriasis. This is a preoccupation with fears of having or getting a serious disease. Most often we treat this through cognitive behavioral therapy because this is dealing with our thinking and our preoccupation with these thoughts. Somatization disorder. This is characterized by many different complaints of physical ailments, and we may see these people at the doctor over and over again, but not really being able to find anything wrong. When we talk about characteristics of somatization disorder, it usually lasts several years. It begins before the age of 30, so that would be one of the characteristics when we're looking at making a diagnosis. It's not adequately explained by any independent findings of physical illness or injury, and it leads to medical treatment as doctors try different things to try to help the person get some relief or to a significant life impairment. When we look at the prevalence of somatization, we see that it is more common in women than in men. And it usually, like I said, begins in adolescence, and it's 3 to 10 times more common among women than men. For some reason, it also tends to occur more among less educated individuals in lower socioeconomic classes. These disorders often co-occur with major depression, with panic disorders, phobic disorders, or some generalized anxiety disorders. It has a pretty low or pretty poor prognosis. It may go into remission spontaneously, but because that we cannot find actually a physical or medical factor, it may continue. Now, why does a person develop this? What are some of the causal factors? Basically, they haven't found any scientific reason, but there is evidence that this disorder may run in families, and there could be a familial linkage between antisocial personality disorder in men and somatization disorder in women. So, could be genetic and things, and it could be that people with somatization disorder tend to pay attention to and show really strong perception of any bodily sensations. So, similar to hypochondriacs, but they tend to catastrophize about any minor feelings or changes that they have in their body. These, as you would imagine, are very difficult to treat. Usually treatment involves a combination of some medical management along with cognitive behavioral therapy. Next, we have pain disorder. And as we go through these, you're going to see that they all have some similar characteristics. So I'm going to encourage you to read your book carefully, highlight the characteristics so that when you are taking your next exam, you can quickly access this material. But when we talk about pain disorder, This is characterized by persistent and severe pain in one or more areas of the body. Now, what makes pain disorder different is it's not intentionally produced, it's not feigned or faked. There may really be some medical condition that contributes to it, but the pain is very real to that person, and it can hurt as much as a true pain coming from another source. But this pain is not, I guess there's no reason for it. They're not being poked with a knife. There's not a muscle that's pulled or irritated or something. Many times people with pain disorder are unable to work. They go on disability. Sometimes they can't perform their other daily activities. Then when they have this avoidance of physical activity, it can lead to social isolation. This can lead to depression. Then they begin to lose their physical strength and endurance, and then that can actually cause the pain to be worse. So you see how it can get in a vicious cycle, and that's why it's important to diagnose and try to treat it early on. Treatment involves cognitive behavioral techniques, and when we look at the different types of pain disorder, there's some subtypes. Again, we would try to use the cognitive behavioral techniques in those. Next, we've got illness anxiety disorder. Some of the criteria for a diagnosis of illness anxiety disorder are preoccupation with having or acquiring a serious illness. And you see there they experience high anxiety about this. So it's tied in with some symptoms of anxiety. They have, like I said, this high level anxiety. They perform excessive health related behaviors, might always be checking their body, looking at moles, seeing if they've changed, checking for anything that could be cancer, those types of things. This preoccupation with becoming ill has to persist for at least 6 months. And if it's not explained by some other mental disorder, such as the somatic symptom disorder, generalized anxiety, obsessive compulsive, then we look at a diagnosis of illness anxiety. Conversion disorder. Conversion disorder is actually one of the most interesting and kind of confusing patterns in the study of psychopathology. We don't know a lot about it, but what we're looking for is one or more symptoms of altered voluntary motor or sensory functions. There's a deficit there, and people's motor or sensory functions are affected. This symptom or this deficit can't be explained by anything else because there's not neurological or true medical conditions, but these symptoms do cause very significant distress or impairment socially, occupationally, or in other areas of their life. And so, you know, you may begin to believe that this patient really has a medical condition. Now, when we look at conversion disorder, theorists have identified some gains that people get from this. First, the primary gain would be the continued escape or avoidance of stressful situations. Now, the person doesn't really see the connection there, but by having these symptoms, it allows them to avoid situations that they may not want to go into. And then, secondly, when we talk about secondary gains, we refer to some of the advantages of the symptoms. For example, when we talk about a secondary gain of a conversion disorder, then we're referring to the attention that a person receives by having these symptoms or these pains. Right along with this, we have two other disorders, malingering and factitious disorder. Now, malingering and factitious disorder are very similar in their symptoms, but what distinguishes them is you look at the goal of the behavior. Someone that is malingering, they're motivated by external incentives, missing work, getting out of obligations, and they may get to avoid social situations that they don't want to be a part of, or they may obtain some financial compensation. So if this person is has the goal of avoidance, then we would diagnose them with malingering. With factitious disorder, we look at a goal of the person intentionally producing these symptoms to obtain or to maintain the personal benefits of playing this sick role. And in factitious disorder, we'll even see people undergoing repeated hospitalizations to get the attention and the concern of the family and medical personnel. Now, these people are very aware of what they're doing. They may even take medication to simulate real illnesses. And we need to watch this because they could actually harm themselves by trying to mimic or do something that makes them sick so that they can get this attention. Now, when we talk about factitious disorder, one thing I want to just point out, it's on page 275 in your book. You'll see that we have something called Munchausen's syndrome by proxy. And what this is instead of, let's just use the example of the mother there, instead of the mother faking being sick, what they do is they produce this illness, or whether it's medical or psychiatric, in another person who's under their care. Usually it ends up being the child, and what happens is the mother brings her child for treatment of a medical condition that she has deliberately caused. If you look at the picture there, you see a little girl who's 8 years old, and over a period of 20 months, her mother took her to the hospital more than 130 times, and this little girl underwent 40 surgeries. And so, doctors and nurses saw that the little girl's condition was always worsened after her mother visited her in the hospital. And for the safety of the child, she was removed from the mom. And in factitious disorder, sometimes for the safety of the person, they may be hospitalized or institutionalized. What are dissociative disorders? Now, usually people are very interested in this. This is kind of what we've seen in the movies and different things. But when we talk about dissociative disorders, we're talking about a group of conditions that usually involve disruptions in a person's normal functions of consciousness, memory, identity, and perceptions. These are some of the more dramatic phenomena, and a lot of times when people think about psychiatric conditions, they will, think about these. So, some of the most common dissociative disorders, we've got depersonalization or derealization disorder, and this is where a person's sense of reality is temporarily lost, or in the depersonalization, a person kind of loses their own sense of self temporarily. With dissociative amnesia or dissociative fugue, we see that a person may have an inability to recall important information about a traumatic or a stressful event. It's not just ordinary forgetting. It usually is focused on, a certain time period or a certain event. Now, when we talk about dissociative fugue, this is kind of a more serious dissociative amnesia. This person retreats even further from their real life problems. It's kind of not a defense mechanism, but, well, it is a defense mechanism. We talk about fight or flight. This is actually flight. They not only have the amnesia, but they may also leave their home, set up a new identity, just start working somewhere else and things. But what's kind of weird about this is that this person may be unaware of these memory losses, and then they just come out of the fugue one day and they find that they live somewhere that they're not familiar with. They work somewhere else. They don't know how they got there. So this is a very serious disorder. And then we have dissociative identity disorder. And when we talk about dissociative identity disorder, we used to call it multiple personality disorder. And again, this is kind of what we've seen in the movies where a person has two or more distinct personality states. And these may be people in their mind that know each other or don't know each other. They can't attribute these symptoms to the use of some substance, or it's not a big trip because they're using drugs. It's not a hallucination. It is actually two or more distinct personalities, and each identity in that person has their own story. They have a different personal history, a different self-image, a different name, and things. So the person would have an identity that was their real name, and that would be the host identity. And then they would have these alter identities, which may be anything from a child. It may be a person that they actually write different. One wears glasses, one doesn't. One can speak a foreign language. So it gets very, very complex. And like I said, we used to call it multiple personality disorder, but multiple personality was kind of misleading because there's not all the different identities occupying that person at the same time. They are all their own distinct personality that appear at different times, and that person actually switches to being a different person. So that's why we've changed the name to dissociative identity disorder. Okay, we've already kind of talked about derealization and depersonalization disorders, the dissociative amnesia and the dissociative fugue, and then the dissociative identity disorder. There's a lot of controversy about dissociative identity disorder. Again, a lot of us have seen this in the movies and things, and there's a lot of controversy about, is the disorder real or is it faked? And if it is, a real disorder, then how does it develop? Was it an escape, a defense mechanism to protect the host? We don't really know. Some people believe that recovered memories of abuse that come out during the disorder are real. Others believe that they are false and may even be planted by a therapist. And if abuse did occur, was that one of the causal factors in the dissociative identity disorder? Treatments and outcomes in dissociative disorders. Needless to say, this could be a very long process depending on the number of identities. Hypnosis has worked, and in fact, people have had good luck with that because they've been able to kind of talk to the different identities during that time. Some attempts in therapy are to try to integrate the separate alters, into one. If it is related to abuse or some other post-traumatic incident, doing some treatment for that. So it is very controversial still at this point. But what's